Hello, I'm Dr. Leon Popovitz. Thank you very much for joining me today. Today I'm going to talk about the most recent new AAOS guidelines for the treatment of rotator cuff tears. The AAOS is the American Academy of Orthopedic Surgery. This academy is essentially an academic group that is highly respected, particularly amongst orthopedic surgeons, and it's for orthopedic surgeons primarily, that guides us as to the proper education and management of orthopedic patients and conditions. And very often they put together guidelines based on a diagnosis as far as what is the ideal treatment based on scientific facts and papers. And they often update their guidelines depending upon how new information evolves. And most interestingly, recently they updated their recommendations and guidelines as it relates to the treatment of rotator cuff tears. Now, the rotator cuff is a group of tendons in our shoulder that helps with the stability and particularly the movement of our arms. So it allows us to raise our arm in different directions and helps to keep that shoulder bone, that ball, inside the socket. So I jotted down some notes and I thought it would be nice for us to discuss it and share with you. First off, they noted that the treatment of a rotator cuff tear, and this is, they categorize it as rotator cuff disease. So it could be a full tear, a partial tear, high-grade partial tear. More often than not, a lot of conditions that really lead to surgical treatment is a full tear. And they say that physical therapy and surgical repair both can be an effective method of treatment to treat the symptoms. That's something we essentially knew in the past, and it's essentially supported. What they have pointed out this time is that doing only physical therapy may alleviate your symptoms, but only a surgical repair will heal the tendon back on the bone. It sounds simple, and we essentially always knew that, but this is essentially being in writing and documented. And it's particularly interesting because if you choose to treat your rotator cuff tear with only physical therapy, no surgical treatment, without a repair, that tendon will not go back onto the bone, will not reattach back onto the bone by itself. And the concern is, if your function is okay now, the concern is that as time goes on, a tear will gradually get bigger and bigger and bigger. And as the tear gets bigger, your strength becomes less and less and less until you potentially may develop significant weakness, difficulty raising your arm altogether. And it may reach a stage where it's not repairable because the tissue starts atrophying, starts shrinking and shrinking and shrinking. And actually there's something called fat deposition, where it essentially fat comes in and replaces that tissue. It's extraordinary. But unfortunately, if you allow a tear to continue to retract and atrophy, that condition can become very, very serious and difficult to handle. So it's something you should be aware of. It's almost like the best analogy I can give you is a piece of paper. So you take a piece of paper. So if the tear is this big and you're doing okay, it's fine. But in time, it can continue to get bigger. So if the tear gets too big, it often is not repairable. There are alternative surgical procedures such as what's called the reverse shoulder replacement. There are grafts that can be done for those kind of conditions. But you really don't want to get to that point. You want to manage it when it's much easier to treat. So the healed, repaired rotator cuff tears, conclusively, people have a much better outcome, functional outcome. The other thing they touched upon, which is very interesting, is rehabilitation. So typically we put a patient into a sling and keep them immobile. The standard really typically has been 1 month, 4 weeks. And we ask them to avoid anything that involves active motion, meaning don't tell your brain to raise your arm. You can do passive motion. You can take your other hand and raise it that way. Or you can have the physical therapist take your arm and raise it that way. That's passive motion. But if you yourself tell your arm to go up, then it's going to make that tendon pull on the bone to raise that arm, And that theoretically has always been the consensus that that might interfere with the healing. Most recently, the guidelines are saying that you could potentially start moving that arm actively much sooner, even as soon as a couple of days or a week. That I have not done. I have done in the past for labral repairs, for cartilage repairs in the shoulder, deeper inside the ball and socket, which typically a lot of surgeons immobilize post-operatively for an entire month. I've been much more active with that and allow my patients to move their arm very often, much earlier, as long as they avoid certain extreme motion. But the labrum potentially does not get pulled upon when you're raising your arm as much as the rotator cuff does. So now there's some new information, and I'm going to look into it a little bit more and probably be a little guarded as far as having my patients actively move their arms so soon. But on the other hand, I probably won't be as reserved about it if the patients start moving a little sooner, because very often patients come in post-operatively and you see them coming in sometimes without their sling, and sometimes, you hear that they've been moving their arms, and we get a little nervous when we hear that, so potentially now I probably won't be as apprehensive about the situation. The other thing they touched upon are injections, cortisone injections. In the past, or in the present even, a lot of doctors, particularly non-surgical doctors, utilize cortisone injections very frequently for a lot of different things. And that sometimes is good, sometimes it's not always good. Cortisone, steroid, that's corticosteroids, not the steroids that potential aggressive bodybuilders might be using, such as androgen, things like that. But corticosteroids can interfere with your healing. And typically we've been concerned about a lot of cortisone injections for tendons that are cuff tendons that are fully torn, for a couple of reasons. But the main reason is that if it gets to the point where the patient does not improve with the cortisone injection and does require repair, the cortisone may interfere with the healing and the outcome after surgery. I recall there have been studies in the past that have shown that if you do have a cortisone injection and you're planning on surgery, we typically wait at least a month to even 3 months sometimes to allow a little time for that tendon to allow that medicine to kind of come out of that system and have that tendon a little cleaner before the repair. Now they're saying you can have one injection, but only one injection, or if you have a rotator cuff tear. So that's in the guidelines. Personally, I'm reserved about any cortisone injections when there's a full tendon tear, when there's a full rotator cuff tendon tear. If you're absolutely certain that you're not going to have surgery and you don't want to have surgery and your function is not that bad, you still have your strength and you want an injection alternative, I would consider PRP, plasma injections, which are your own blood. We draw it, we spin it, we concentrate it, and we use the most healing tissue in the plasma and inject it. It's been shown to help with healing with partial tears or even potentially small tears. You can make a case that it might help. And really, it's not going to reapproximate a tear that's far from each other. So if the tear is kind of like this, maybe there'll be some help. Maybe if there's a partial tear in the tendon, maybe it would help. But if there's a big tear like this, it's probably not going to heal the tendon. I've never seen that. But it may significantly improve your symptoms. And if that's what you're looking for primarily, then it's a very good option. Certainly safer option. The next thing touched upon, speaking of PRP, is the use of PRP in the operating room once we repair the tendon. This has actually been utilized, and I've been using it for a good long time now, to improve the healing of your repair, improve the chances of that tendon healing and limit the chances of a re-tear. So what we often do is after a rotator cuff repair, to improve the chances of healing, we'll do that spinning procedure, take the blood and spin it and inject it right in the operating room and directly in that site of repair. And that's been fantastic as far as improving healing. And we've been using it a lot. I've been using it for meniscus repairs as well. It's a very, very, very significant improvement in functions. And so mostly recently the guidelines have concluded that that's very effective. It's also concluded that dermal allografts, which are essentially donated human tissue, can be also helpful. And that tissue is essentially sewed upon the repair to promote healing. And it's been shown, based on the guidelines, to improve the healing and diminish the rate of re-tear. In the past, for the most part, I've really used it primarily for very large tears because, like we said before, as time goes on, if it's neglected, the tissue atrophies and there's less tissue to repair. So if you need tissue to repair tendon to tendon, you need a bridge. So we can use these allograft tissues to create a bridge and heal the bone back, heal the tendon back onto the bone and help it heal. It's been very effective. But based on these guidelines, now it's significantly concluded or recommended that you can actually use it for standard repairs. Don't necessarily have to, but you can. Very often I use criteria of the tissue quality and the extent of the atrophy and retraction to determine if I want to use PRP or if I want to even mobilize the patient sooner. Because, for example, if I did a rotator cuff repair and I found the tissue to be not of greatest quality, because not everybody has the same tissue, not everybody has the same tear. Believe it or not, it's not always the same type of tear. These tears look so unique. Almost everyone has such unique patterns. There are certain standard patterns that you typically see, but there's such variations. So if I see a very large tear, if I see the tissue quality is not great, if I see there's atrophy, then most certainly I would not rush to mobilize the patient sooner. So sometimes it's a judgment call, but I certainly would consider the PRP supplement. Or even now, maybe I would even consider the patch, the allograft patch. But ultimately, I think these guidelines are outstanding. I think the big takeaways is that now they're saying, or it's been documented, that you can start moving a little sooner after your surgery. Most certainly a repair ultimately will give you much better functional outcome than no surgery and just physical therapy. And try to limit those cortisone injections to, at the very most, just one. I'm Dr. Leon Popovitz. Thank you so much for joining me.